Yes, okay. Thank you. I'm actually joined on two devices just so that just in case. Okay, good evening everyone and thank you for coming. And just to echo Dr. George's apologies earlier, we were to have this meeting last Sunday, but it didn't happen and notice was short. Trust me, it's all for a good cause, and I'm happy that at least all those children and individuals that were attended to are doing very, very well. And I must really say a big thank you to the WASI team for the incredible work they are doing. Honestly, it is really, really amazing. Um, so yes, I'm Dr. Ayobami Kuyoro. I'm Managing Director, Iwosan Lagoon Hospital, Victoria and Lagos. And I won't take too much of your time. I'll just talk us through, what we do in Lagoon Hospital as a group, and then what we're doing in the Victoria Island facility where we have the cath lab and where the neuroendovascular work has been ongoing in Lagos. So Lagoon Hospital is a private tertiary hospital in Lagos, Nigeria. We are a network of 3 hospitals and 2 outpatient clinics. Now, this is important because each of our hospitals is a center of excellence for, for the major medical specialties. So our hospital in Ikoyi is a center of excellence for critical care and surgery. And there we do a lot of complex surgeries across the surgical specialties from, complex neurosurgeries, abdominal surgeries. I know a lot of us here are, neurosurgeons. So I thought to mention that, and we do have a microscope that we use for our, open neurosurgeries. We also have our Center of Excellence for Mother and Child, which is the hospital in Ikeja. And there we take care of, women and children, really from conception to adulthood. And there we do, complex gynae surgeries, and we have a neonatal ICU. So we're able to take on people with high risk pregnancies, and, we take on babies as little as 25 weeks. We're able to look after them in our NICU. And just a few weeks ago, we were able to take care of quadruplets in there. So really, we are doing some amazing work there. Now back to our hospital in Victoria Island, where I sit. That's a center of excellence for cardiovascular care. And there, we provide a wide range of cardiovascular services and peripheral endovascular services, which is where the neuroendovascular work comes in. And honestly, really, work with WASI has been really, really remarkable. So many, many amazing stories, so many people smiling again, after being down. And to be able to do this, in the cath lab in a way that is minimally invasive, I think it's really, really amazing and should be commended. And, more so with these workshops that they do, that WASI organizes regularly, I think it's really great to sort of pass on knowledge and be able to build local capacity here in Nigeria. So I won't take too much of your time. Again, just to add that Lagoon Hospital is the only only hospital in Nigeria that is JCI accredited, and JCI, that is Joint Commission International, they're a world leader in healthcare accreditation, and they are the evaluator of the most rigorous international standards in quality and patient safety. So we had our first accreditation in 2011, and we have been reaccredited 4 times: 2014, 2018, 2021, and 2024. So really, our patients are in a system where they get access to the highest quality of care, really of international standards. So we are sure that if a patients come to us, we will look after them, and yes, and they'll be fine. So thank you, everyone. Thank you for your time. Dr. George, over to you.
Okay, thank you so much, Ma, for that. That was very good. I am. Oh, I'm still muted. Hello, can everybody hear me?
Yes, we can.
Yes, Dr. George, thank you. We can hear.
All right. So thank you so much. And without further delay, I'm going to let Dr. Kafo give us a little bit of talk about what WASI does before I hand over to Dr. Martinez. So Dr. Kafo will talk about WASI for a few minutes. Thank you.
All right, thank you, everyone. Thanks for coming. Dr. Quiro, thank you so much. Dr. George, thank you. So can everybody see my slides?
Yeah, but do you want to switch the display setting?
Oh, you're seeing just the, okay, hold on, let me see. Is it better?
Perfect, yes.
Okay, all right, that's fine. All right, so good evening, everyone, or good afternoon, depending on where you are joining us from. So my name is Dr. Uchenna Okafor. I'm a neurosurgeon and neurointerventionalist. Currently, I work here at the Westchester Medical Center in New York. I'm also an assistant professor of neurosurgery at the New York Medical College, and I serve as the CEO of the West African Stroke Initiative. This has been an initiative that started about 2 or 3 years ago, 3 years at this point, with some amazing group of people who have made this possible, without which this will be impossible. And of course, the partnerships were forged with the Lagos University Teaching Hospital with Professor Bankole at the helm of it, and all the other team members, as well as our amazing friends and colleagues who have come to volunteer and who serve as faculty on our board, and of course our fellows, without which this will be impossible. So just a quick summary, because I'm sure everybody came to learn something tonight from Mesha Martinez, who will be talking to us about pediatric neurointervention part 1, but just a quick flavor of what we're about. So the West African Stroke Initiative, the whole idea was born from a need to try and meet a gap. There are patients who have complex neurological conditions, both brain and spine, who had not been attended to. And hitherto, before then, they say, oh, my head. And they say, maybe it's a witch that has hit me. And they collapse and they die. And meanwhile, these are conditions that could be dealt with. And then we have now a more modern approach, a minimally invasive approach of dealing with these conditions, where we go endovascularly and we take care of brain aneurysms, we take care of patients with AVM, strokes, acute strokes, and can see how we can reduce the morbidity and mortality of these conditions. So all kinds of cases that are coming across that, hitherto people would either just resign and say nothing can be done, or for those who are fortunate enough to come abroad to get these conditions taken care of. But unfortunately, there's some, conditions like a subarachnoid hemorrhage, where people have brain aneurysms, weak spots in the blood vessel in the brain, that hemorrhage, and you can't fly, because if you fly, you even make it worse for yourself. So both for the rich and poor, they need to be attended to locally back home in Nigeria. And of course, the rest of West Africa, where our target is. So we've been able to try and see, can we meet that need, where we can make these services, that were hitherto not available, available and affordable for our people, and bring in world-class experts to come and help out in conjunction with our team, with Luth, and of course in Lagoon Hospital, where we've found some wonderful partnership. So we facilitate world-class comprehensive neurointerventional stroke care with evidence-based, culturally tailored behavioral and transitional interventions in West Africa for both these patients and their caregivers. So we're going to talk about who we are. Just pretty much talked about that. We're a class of professionals that our desire is to see how we can bridge that gap and make sure that these things that are done in America and Europe are available locally in Nigeria, and can be done at the same standards and give the same amount of care to our patients. So who we are, what we do, and what's coming next, and who we're partnering with. So we see here that we have our mission statement. We create, support, deliver, provide, facilitate, we train. One thing that's important to us as well is not just coming to provide care, but also trying to also make sure that this same skill set is passed on to our neurosurgical colleagues there in Nigeria. And of course, very soon, both radiologists as well as the radiologists as well as the stroke physicians can also learn the same skill. Our values are here, accountable, we're focused, respect our patients, we're innovative, we're caring, and our goal is to make sure that the same kind of care that is being rendered here in the States or in Europe is available to us locally at the same level and same standards. And then all that, having to get people abroad and looking for visas to travel and spending their life's worth can be mitigated. So what do? We get involved in endovascular neurointerventions, all kinds, whatever it is, brain and spine. We're able to tackle that, and even try and facilitate open procedures as well with our colleagues back in Nigeria, with Professor Bankole and their team. And of course, we offer fellowship training. The whole idea is that in a couple of years we can turn over and get people to do the same things we do. Currently in Lagoon, we have a monoplane, but of course, the gold standard for us will be to get a biplane machine, which makes it possible for us to do all kinds of interventions. There will be nothing they do in the US we cannot do in Nigeria. So offering exchange programs, hoping that we can upgrade to a biplane fluoroscopy machine that would make things much safer, and we can cover all kinds of things, all kinds of cases. To do this is not cheap. Neurointervention is not cheap at all. So we invite those who are listening. We're looking forward to. Our goal is trying to help our people. Many people can afford this treatment. So as much as we can, we're trying to partner with various organizations to see how they can help to alleviate the costs for our patients, because the hospitals still need to get paid for what they do. So we're hoping our friends would partner with us. Come join us, become a bronze donor, a platinum donor, a gold donor, and all the funds, are channeled towards trying to help our patients get the care that they need. These equipment we're dealing with, some of them run in thousands of dollars. And if not for all the donations and, the help of all our professional colleagues volunteering their time, this would not be possible. So without ado, we just want to encourage us to please get in touch. Our website is right there, www.westafricastroke-initiative.org. Just type it in. George is our local contact, Dr. George. And of course, we have our team members both in Louth as well as in Lagoon. Dr. Kira just spoken to us. So please partner with us. We want to make this possible for our people. And we are committed to training, development, and helping our people thrive. So thank you so much, and thank you for your time. We might take some questions, but probably we'll do them at the end. So over to you, George. Thank you.
Thank you so much, Dr. Okafor. And yeah, that was exciting. All right, I'm just going to hand over to the person everybody came here for, Dr. Mesha Martinez, to talk about pediatric neuroangiography. Over to you. Thank you.
Thank you. Good evening, good afternoon, good morning, everyone. It is so exciting to be here. And again, we apologize for not being able to have this in person, which of course for me would have been the most fun. But so excited to have this short series of pediatric neuroangiography lectures and beyond. And we'll be starting with the first one today and hope to do at least two more, getting into the pathology of what pediatric patients have. But before I begin, I would just like to thank WASI and Lagoon Hospital and administration for allowing me to participate in the care of the people of Nigeria, for bringing me for the very first time to the wonderful continent of Africa and to the largest metropolitan area in all of Africa and Lagos. It was truly, truly
I'm
an
online. I'm
phenomenal
online.
experience for me. And I look forward to continuing our collaboration and our work together. So, a little bit about me. I'm Mesha Martinez. I'm a radiologist by training. I am a big kid myself, and so I love children, although I am trained in doing pediatric and adult neurointerventions. So today we're going to have a little fun. I have no disclosures that are relevant. And I do want, since everyone has the opportunity and we're a smaller group, for you to speak up or write in the chat. And let's get some participation going because it's Saturday night. I'm not going to keep you too long, but there's a lot of things that we can get to learn. And I'm actually going to turn off my camera, and so it's not projecting over the screen. So give me 1 second if I can do that. Oop, boop, boop. Maybe I can't. Yes, I can. I'm going to turn me off. Okay, let's get back to business. All right. So, the outline for today is we're going to start with the basic concepts. The focus of this lecture is to mainly remind everyone of one major thing, and that's kids are not little adults. Okay. And so, we're going to go over what are the nuances when it comes to endovascular care, neuroangiography, that are different from the adult world versus the pediatric world. Number two, case number one, we're going to just kind of we're going to discuss a pediatric case, but go into how the etiologies for diseases in this patient population are different from adults. We're going to do this again by cases. We'll go over what are the indications for diagnostic cerebral angiography. And then we'll divide it up into three sections: what we should be doing pre-op for our children, what we should be doing intra-op for our children, and then we'll go to our post-op and summary. So again, I'm hoping this can be interactive so everyone's engaged throughout this process. Maybe I can get rid of that. I can't get rid of that. Okay, kids are not little adults, and I often use this picture because I find it so adorable, but it's true. We cannot practice on children like we would adults. Otherwise, we wouldn't have a pediatric specialty. So it's very, very important that we realize, even though we've been taught how to do adults and maybe not had too many interactions with children, or maybe we have, there are nuances, there are differences, and it's important to remember that. So we'll start off with the case number one, and this is where interaction begins. This is a true case. All of these cases that I will be discussing today are cases of my own that I was involved in the care. And this is a 16-year-old boy with a history of asthma who was supposed to be coming down for breakfast before he went to school. But his mom found that although breakfast was ready, he wasn't downstairs. She goes upstairs and finds him in his bedroom. He's nonverbal. He's unable, he's just laying in bed. She's trying to get him out of bed, but he's unable to sit or stand, and he's not moving his right side. Mom panics, which of course that's what I would do as mother, and rushes in, well, calls 911. He's rushed to a local hospital nearby where this non-contrast CT head scan was performed. Now, this is a question for the audience. Do you see anything abnormal on the CT scan? Please put the information in the chat or turn on your mic. Is the scan abnormal?
Let's feel free to interact.
This
Anybody?
makes it more fun. Then you don't just hear my voice the whole entire time.
Any takers?
Sure.
Maybe we might call out some people now. General, are you there? Help us out.
Okay, we got someone in the chat saying, I can't see anything on the scan.
I
Thank
think
you.
I see a normal scan for
You
me.
see a normal scan. All right. Anyone else willing to pipe up? Thank you so much for participating. All right. Now I'm going to give everyone a second chance.
Posterior
And
part.
thank you so much for your boldness. Someone said something. Go ahead.
The posterior aspect of the looks a little tight. That's around the cerebellar region. Looks a little tight. That's all I can apart from that.
Okay. Thank you so much for participating. I know Sometimes putting yourself out there, you're like, oh no, but no, this is a good crowd. We're all learning here. So I'm going to give you another opportunity to have a second look. And what I've done now, I've given you the standard CT head soft tissue window. But now on your right side, uh, we're seeing the stroke window, where we're increasing the attenuation between gray matter and white matter. And I'm going to remind you, he's 16 years old, and his issue is right-sided weakness. Would anyone like to gauge and tell me what they think now? All right, for those who participated, how do you change your mind? Or do you still feel like
I
the
think
scan is normal? Go ahead.
looking at
Think, hello, can you hear me?
Again,
Yes, we can.
There is loss of insular ribbon on the left.
yes, yes, absolutely. Here we can see our caudate, our putamen, our internal capsule. But on this slide, can you find these gray matter structures as well as the white matter structures? Indeed not. And even if you look here in the frontal region, here we have loss of gray-white differentiation, and here we have it maintained. And so this is consistent with an acute ischemic stroke. Now, again, we're participating, and everyone gets a turn if they would like. What are the causes for stroke in the pediatric population? What is the first thing that comes to mind? Causes of ischemic stroke. Very
sickle
good,
cell anemia.
Alvin. Sickle cell anemia. I love it because that's actually the number one cause all around the world, all comers for the pediatric population. Someone also said cardiac defects. You guys are on the ball because, yes, kids with congenital heart disease are going to be the second largest population presenting with acute ischemic stroke. I just
Well,
knew
we have two
that
more
someone was going to
vessels, two more
say it
compressive
again.
vessels, two more compressive vessels. Vessels being
Compression of
compressed.
vessels. Absolutely. You guys are awesome. I love what I'm seeing in the chat. I love what I'm hearing by voice. Thank you so much for participating. So, yes, some type of arteriopathy, meaning just abnormality of the vessels. You know, dissection, you can have focal cerebral arteriopathy. Someone put moya moya in the chat, vasculitis, vascular malformation, indeed, and trauma. So, when it comes to the etiologies for ischemic stroke, the most common cause for an adult patient would anyone like to give a go for the adult population? Hypertension, someone said. I like it. Diabetes with the combination of plaque formation. Sounds familiar. But note that here, the risk of having plaque or high blood pressure and causing ischemic stroke is way down on the list, low on the list for children. Yes, it can happen. Anything can happen, but unlikely. So the first thing we have to realize is thinking outside the box. And for this 16-year-old young patient, he actually had an intracranial dissection, spontaneous. So arteriopathy, someone put atrial fibrillation. Yeah, that's a good one for the adult population, but then can come into the the pediatric population, but would be super, super, super rare. But the young man who presented not coming down for breakfast had a spontaneous intracranial dissection of his left middle cerebral artery that was causing stroke. And so here is the page I stop and pause and talk about empathy. A lot of times, those who go into adult and don't want to do pediatrics, they say they don't want to do that because parents are crazy. And you have to realize that if it's your child going through this situation, that it can be pretty devastating. It could be very scary. It could be sometimes fear comes out as anger. Sometimes it comes out as aggression, or but it's all just related to it's that parent's child, and they can't believe that their child, who was healthy all their lives, which is often the case with pediatric neurointervention, now they have a condition that can risk them having an impairment for the rest of their life or not recovering. And so I put these two slides in just to say part of pediatric neurointervention is important to remain empathetic. Compassion is key. And yes, does it take the extra time to make the explanations and make things clear? Absolutely. Is it very, very important to explain what's happening to a parent about their child? 100%. And so knowing the differences and the nuances and being confident when these parents are going through the most devastating times of their lives becomes very, very, very important. All right, case number 2. Now we're going to do another game where it's what is the indication for cerebral angiography? I'm going to give you a case and you're going to say yes or no whether this patient should actually undergo angiography, diagnostic cerebral angiogram. 12-year-old boy with a history of an undiagnosed sinus pericardium who presents status post cerebral venous thrombosis complicated by venous stroke. Now, those are a lot of terms, very pediatric specific, and I'm going to break it down a bit. He's 12, not quite yet finished with puberty, but he was in school, started having seizure-like activity, was rushed to the hospital, found to have a vein that actually connected to the veins inside of his brain, but also came out to his scalp. So that's the definition of a sinus pericardium. When you have venous drainage of the brain peripherally through the scalp, outside of the body, outside of the calvarium. So how many people would say that this young man needs a diagnostic cerebral angiogram? Feel free to put it in the chat or speak up. No takers? Okay, we'll go on to number 2. This is a 4-year-old boy with history of febrile seizure who was found to have incidentally, maybe incidentally, on his brain MRI to determine why he was having seizures, even though they thought it was febrile seizures. He was found to have a dissecting fusiform aneurysm. Does this patient get a diagnostic cerebral angiogram? Feel free to speak up or put it in the chat. The 12-year-old should get a DSA. Awesome. What about this 4-year-old? Let's keep going. Yes, someone said. This is an 11-month-old girl with history of HHT, hereditary hemorrhagic telangiectasia, which is associated with a predisposition for developing vascular malformations in the brain, the spine, and in the lungs. This little baby who was being screened, presented with a subpeel hematoma, asymptomatic on MRI imaging. Should this baby, 11-month-old baby, get a diagnostic cerebral angiogram? Someone recommended CT angio. No. All right. This is a 16-year-old teenage boy who presents with headache and 2 episodes of seizure, and he's found to have a tangle of vessels on his MRI brain. Should this patient get a diagnostic cerebral angiogram? Someone said MRV. Yes. All right. This is a 15-year-old teenage girl who presents with multiple TIAs and is found to have narrowing of the distal right MCA on CTA. Should this young lady get a diagnostic cerebral angiogram? Yes, 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 he should. That was for the last patient. Anyone, how about for this 15-year-old teenage girl? All patients should get it, yes. This is a 17-year-old teenage boy with history of headaches and intermittent neurological deficits. It should read, he's found to have a DVA with surrounding parenchymal brain edema. Should he get his conventional diagnostic cerebral angiogram? Yes. Last one. This is a 6-year-old girl with recurrent strokes, but a normal CTA. Should she get a diagnostic cerebral angiogram? Yes, DSA, yes. So let's talk about each of these cases. These are actually cases that I had, and the answer is yes for all of them. The reason being, very shortly, this 12-year-old boy had an undiagnosed sinus pericranii. Parents didn't know it was there, although he had a significant soft spot in his forehead. He ended up undergoing diagnostic cerebral angiography because they actually had to do a thrombectomy because he wasn't responding to anticoagulation. It also told them, how does his brain drain? This is information that is dynamically encountered and can't be picked up by CTA or MRA because it doesn't have the temporal resolution. And so he underwent a diagnostic cerebral angiogram. This 4-year-old boy who had this dissecting fusiform aneurysm also underwent a diagnostic angiogram of his aneurysm that would cause him to bleed intracranially. 16-year-old teenage boy with headache and 2 episodes of seizures had a tangle of vessels, which were eventually diagnosed as an ABM, which always should undergo diagnostic cerebral angiography for treatment planning to determine if there are emergent features that should be treated right away and also get a better understanding of the architecture. 15-year-old girl with TIAs have a narrowing of the distal right MCA, also underwent diagnostic cerebral angiogram for better improved spatial resolution to determine if she was suffering from a vasculitis. And not always can be picked up on CTA. 60-year-old girl with recurrent strokes but normal CTA. Again, the spatial resolution is much higher in diagnostic cerebral angiography. And so sometimes there are things you can find on angiography that you won't see on CTA. The 11-month-old girl, she ended up having a micro AVM that actually had caused her to bleed. The referring pediatric neurosurgeon did 3 to 6 months of MRI follow-ups, but because it was a micro AVM, it never would have been discovered on angiography and was actually quite difficult to see on MRI, and was actually quite difficult to see on angiography if it wasn't for the dynamic nature and seeing the early draining vein. Lastly, anytime we all know that DVAs are no-touch lesions. However, sometimes they can become obstructed or stenosed and cause issues with venous drainage. This, doing the diagnostic cerebral angiography, can also reveal small AVMs that are feeding the DVA that are also causing problems. So yes, all of these patients deserve a diagnostic cerebral angiogram. So diagnostic cerebral angiogram comes at risk, but in experienced hand, the risk of causing a complication such as stroke or bleeding, dissection is less than 1%. It is 0.4%. So the reason why we do them is for stroke, to figure out why a child is having one and trying to determine if there's some type of arteriopathhy. Vessel injury is not uncommon. Someone falls on the monkey bars and dissects the carotid, throws emboli intracranially. Vascular malformations, abnormal vessels that are seen on imaging, they need further characterization that MRI and CTA cannot always give. And then it's very important to realize how important the venous circulation is involved with the brain. We're finding that out more and more with study of the lymphatic system, which is responsible for cleaning the brain of its toxins and is believed to actually drain into the venous circulation. So the venous circulation is very important. Case number 3. This is a 2-year-old girl with abnormal red reflex, and I thought I would bring up this case as a blast from the past for the talk that I was able to give under the WASI collaboration. How many people are familiar with this disease process? I'm going to give you another picture first, actually, before I give you another picture. Which eye is abnormal? The right eye or the left eye? Please feel free to speak up or put it in the chat. The right eye or the left eye? 50-50 chance. All right. Right eye, someone said. I like it. Anyone else willing to take a gander? All right, that is correct. So here we have an example of leukorrhea, where we're actually seeing that the disease has progressed so much that the pupil is abnormally dilated, and we're actually seeing the tumor itself reflecting the light. This is the normal side. This is what it would look like when they're doing an exam under anesthesia, where the white tumor is what we would call retinoblastoma. So if you remember from last time, and I won't go into this too much, this is about severe disease that you can get, group D. Group E actually is when it metastasizes outside the body, but this is about severe as it can get for the eye itself. The most common intraocular neoplasm found in childhood. It could be sporadic or it could be from a germline mutation, and the diagnosis is usually in the first 4 years of life. Leukorrhea, a loss of the red eye reflex, is one of the signs, although with our cameras today automatically fixing the red eye reflex, we have to go with this increased reflection of light. Those who have a genetic germline mutation are going to be very young. Their bilateral eyes are going to have the disease, and they're going to have a greater risk of brain and body cancer. In the US, there's only 200 to 300 cases per year. Of course, with endovascular treatment, we can now keep them from having systemic chemotherapy and deliver the chemotherapy in a focused fashion, a small amount to bathe the entire eye through the ophthalmic artery. So, for this baby, if we are preparing for her case, how many people would perform labs? You can write in the chat or you can just speak up. She's 2 years old, no past medical history. How many people will perform labs? All right. No one wants to take this one. That's okay. For this patient, we would because she has a cancer diagnosis. But we have found with interventional radiology and neurointerventional radiology for patients who are absolutely healthy, no past medical history, we don't have to establish a baseline. More than likely or not, the labs will traumatize them and they're normal. If the child has a cancer diagnosis, we will do baseline labs. If the child has a blood dyscrasia, we will do hemoglobin platelets or CBC, a PT, and INR. If the child has renal impairment or failure, we will check her creatinine. But no, we will not establish a baseline in a healthy child, even if they're presenting to the hospital with some type of AVM. We'll do the diagnostic neuroangiogram, and these are elective procedures. These are not children who are being admitted to the hospital. We're talking diagnostic neuroangiogram. All right, case number 4, and then we'll go intraop. This is a 14-year-old healthy teenage boy, no past medical history, who had been having back pain for 4 days and kept getting worse. He kept complaining about it to his parents. Then finally, on that Saturday, he woke up with the worst headache of his life. He kept complaining his head was hurting. He suddenly vomited, and then he passed out. His parents immediately took him to the emergency room where MRI was done because the boy was not able to move his lower extremities. And these were the pictures that were obtained. Now, the simple question is, although we have neurosurgeons on this call, is this normal or abnormal? Here we have T2 sagittal images of the thoracic spine. And here we have coronal images. T2 weighted, we can see the CSF is bright. can see our spinal cord is isolintents of the thoracic spine, normal or abnormal. He has a conus ABM. Someone just decided to slam dunk it. Amazing. So yes, he does. And here we can actually see what we call perimedullary veins that are congested due to this ABM within the spinal cord. So this is a spinal cord ABM, another etiology that children can have. And here we can actually see what we call an aneurysm that ruptured and caused him to bleed. This is in the T10 and T11 area. And here in red, I've highlighted the vascular flow voids, which are within the spinal cord parenchyma. And we're circling the hemorrhage that happened in the spinal cord that caused them to lose lower extremity sensation. Can be congenital, can be genetic, can present with hemorrhage, mass effect, or still phenomenon. All right, so as we're preparing to take this gentleman to our angio suite, there's a lot of things we must do intra-op. Normally for our pediatric patients, we put them under general anesthesia. This keeps them from having a horrendous experience and decreases anxiety if they have to come back. For our little people, the ages of 5 and below, the common femoral artery and the common femoral veins sit on top of each other. So in order to separate them to gain access, we will actually put the patient in a frog lateral position. This pulls the common femoral artery away from the vein and decreases the risk of causing an AV fistula. An ultrasound for our little tiny people is important to obtain access. Here we have the opportunity, while I was joining you guys for these cases, to use the pulse oximeter to make sure the common femoral artery remains patent throughout the procedure, which is important for tiny little vessels. And here is a flow limiter, something that we put on our femoral sheath to ensure we don't overload the volume of our pressurized heparinized bags into the baby. It's very important to not have fibers, which can be introduced into the body and actually go into the vessels. This is a pathology picture of a fiber after a baby underwent enucleation for an eye for retinoblastoma. It was actually found inside the vessels of the eye. We like to do our diagnostic cerebral angiograms with the low profile system. One of my favorite sheaths is this 4 French Cook sheath. I normally do not go higher in size than this. And then the angle for a French diagnostic catheter. We ensure that our positioning of our head is optimal in order to see pathology and that the skull is not overlapping with the vessels inside the brain. Radiation safety is hugely important for the pediatric population, but your adult population and for you, those who are in the angiography suite, will always get scatter radiation from the patient. When you start hitting 5 to 10 grays, and someone asked me this question while I was there, you start risking getting skin burns. If you hit 10 to 15 gray, you start risking skin damage. So it's very important to pay attention to optimizing radiation throughout the procedure, before the procedure. Here we have our basic picture of our image receptor. Some people call it an SID. Some people call it an II. Some people call it an image receptor. Here we have our patient on the table. Here we have our x-ray machine. We want to make sure our patient is far away from the x-ray beams and very close to the SID, II, or image receptor. This decreases radiation significantly. We also want to use this collimator to focus on the area of concern that we want to see and not the entire body because it reduces radiation. And then we're almost done here post-op. We want to make sure that we tuck the patient in, we document accordingly, but we want to figure out why did that patient bleed and investigate what caused an arteropathy, an ABM, a malformation. Likely, it's not uncommon for children to have underlying genetic conditions that can lead to these issues. And so, yes, we have come to the end of part 1 where we remind everyone, if you don't remember anything of what I said, that kids are not little adults. And everyone in the audience and everyone who was with me on the mission that I just came from last Saturday, you get a first prize for your kindness, your hospitality, for the true care that I've seen that you have for your patients. Thank you so much for listening. Thank you so much for having me. And please feel free to reach out anytime if you have any questions.
Misha, thank you so much. That was awesome.
Thank you for having me.
Prof, are you around? You can help us with the question session.
Okay, yes, I am. Well, thank you, Misha. That was really nice. You obviously are a born teacher, and I can imagine that the next few sessions will be just as interesting and as stimulating. So I don't know if you have questions. Of course, the lecture itself has been really interactive, but we may have questions. So please just signify on the chat, or either with your questions, you can write it, or you can unmute and raise your hand and unmute so that we can take questions. We've had, I think we're on time, we're within the hour, so that's good. So we can take questions. So maybe some of us that were on the mission over the weekend, if you have any questions based on that or based on what has already been shared, please feel free to ask them.
Yes, and so the next two lectures will be on AV shunts and vein and Galen malformation, as well as other pediatric AV shunts that are very specific to children. And then the last one will actually be on cavernous carotid fistulas in regards to the cases that we did prior. I knew it was going to be some time tonight. I really wanted to reiterate some of the basics of pediatric neuroangiography, just to solidify some of the concepts that we learned last week. But please feel free again, if you don't have any questions today, reach out to me anytime. I'm happy to take questions.
Sorry, Martinez, can I ask a question?
Absolutely, please.
Yeah, so just a brief introduction. My name is Joseph. I'm from Dublin Neurosurgery here. I want to ask you, you said sickle cell disease is the #1 cause. In Europe, we don't seem to have a lot of sickle cell. So what's the #1 cause in the Western world?
In the Western world, it's sickle cell. I actually gave a talk in regards to this. Well, when you do the global accounting of pediatric childhood stroke, it's going to be sickle cell. But when you start getting into places that may not have that risk factor because where they're coming from, it would go to congenital causes and arteriopathies. So, very good question.
Thank you
Do
so
you
much.
guys see oh, of course, do you guys see stroke in children in Europe? I have a few friends there.
You
It
have
was
a,
scattered throughout there. It's not a small place.
oh, okay.
Are you seeing stroke in children there where you're practicing? Ischemic stroke.
Sorry, I muted myself.
No worries.
Yeah, we do, but I'm not in the pediatric neurosurgery at the moment, so more
Gotcha.
into adults.
Understand. Understand. Any other questions?
Let's see. I don't see any other hands raised. Any other questions?
I don't think so.
Well, I think your lecture was really quite self-explanatory and probably just enough to whet the appetite against next week.
Hope
So I'm
so.
sure, yeah, I'm sure we'll have more questions then. Yeah,
Awesome.
great.
Awesome.
All right, great.
Everyone have a wonderful night. Thank you so much for having me and your country. It is a experience of a lifetime. And I have posted my first LinkedIn chat and Twitter X chat. And I've actually gained 80 followers on Twitter. So I look forward to continuing. 80 guys. I've never trended on Twitter ever. Okay. Or X or whatever you want to call it. Ever. People are super excited about WASI. They're super excited about Nigeria. They're super excited about this collaboration that's going on. And I'm super excited myself and I look forward to more.
Great, awesome. Well, just to round up and just to thank everyone who's on the webinar this evening. Special thanks to Mesha herself and Dr. Okafor and the WASI team. He's gone through a lot of what has been done over the last few years, and what I see happening, and you can see that already beginning to happen, is raising up interest, raising up skills, increasing the knowledge to even make the diagnosis, and in a very short order, the skill sets to be able to do the interventions to confirm the diagnosis and then go on to treat. I think we've started, and we will definitely continue by God's grace and with the good help of well-meaning people both within and outside the country. So I also want to thank the Lagoon Hospital team for being willing to partner with us on this journey. And it's not a sprint, it's going to be a long haul kind of journey, but I'm sure we will get there in sooner rather than later. And we look forward to having as many of us on board when we're able to get to that place where we have on ground, fully trained people who can do all the not all, at least do the basic ones and do the advanced ones, and we'll get more people coming in. So thank you all once again, and I think we'll have a great rest of the weekend. Those of us in the US will continue the rest of the day, and some of us it's close to 9 now, so I think we can call it a day now. Thank you all. God bless.
Thank you. God bless
Bye, Nisha.
everyone.
Thank you,
Bye.
Rob.
Bye.
Thank you so much. Misha, thank you.
Of course, of course. Take care, everyone.
All right, good night, everyone.
Good
Dr.
night.
Squiro, thank you so much.
Thank you.
You're welcome. Thank you so much, Dr. Kapo. Thank you so much, Misha.
Oh, my
Amazing, amazing
pleasure.
stuff. Thank you, Dr. George.
Thank
All
you.
right.
Thank you. Thank you.
Yeah,
Enjoy
thank
Take
you,
care.
Dr.